Hello, Dr. Raymer here, and today we're going to talk about prenatal development. And specifically, we're going to talk about factors in the prenatal environment that shape our development and influence how motor and other types of development proceed. Now, we talk about typical human development or average human development. Although we need some norms to facilitate comparisons, and typically everyone attains the same mature human behaviors, we recognize that the rate and ultimate level of achievement vary enormously. So typically is probably a misnomer here. We all start from a different place genetically. That's one set of factors. In addition, other experiences, including other unforeseen factors, occur throughout our lives, and those crucially alter the course of all domains of our development. And this process starts very early. So what we're talking about today is how our development is crucially shaped by our prenatal, literally prior to birth environment. So this schematic summarizes how many elements of the prenatal environment influence development. And what this article is talking about is how things in the prenatal environment impact our risk, or the risk of children, of developing neurodevelopmental disorders after birth. So in some of these factors, MIA stands for maternal immune activation. So what infectious agents is mom exposed to during pregnancy? Drug exposure of the developing baby via mom. Undernutrition or malnutrition, two slightly different terms. We'll define those in just a few minutes. How the maternal metabolic environment influences baby. And a relatively new consideration, which is maternal stress. How does psychological stress impact embryonic and fetal development? And this article talks about how all of these factors create a fetal environment that confers differential risk to a whole host of neurodevelopmental disorders. So everything from ASD, autism spectrum disorder, ADHD, attention deficit hyperactivity disorder, to intellectual disabilities and motor disorders and others. Now, when we talk about prenatal development, we divide it into three big phases. So first we have the germinal period, or the pre-embryonic period. This is the first 2 weeks of prenatal development. Then we have the embryonic period, which is the start of week 3 to the end of week 8, so weeks 3 to 8. And the fetal period, which is week 9 to birth. And so you can see the germinal period is the shortest, then the embryonic period, and we spend most of our time prenatally as a fetus. But what we'll see is really critical events happen in the first 8 weeks. Now, an important thing to note is that these represent conceptional ages. So they are measured from the moment of conception, when sperm meets egg. That is different from gestational age, which is how most pregnancies are tracked. So gestational age, or GA, this is often abbreviated, is measured from the first day of the last menstrual period. And this is used as the marker based on an average 28-day cycle, because on an average cycle, the first day of the last menstrual period is about 2 weeks before ovulation. So we use that to estimate the timing of ovulation and therefore of conception. Now, GA is only accurate if menstruation is regular, if it happens on exactly a 28-day cycle, which in many women it doesn't, and if menstrual dates are recalled and reported accurately. So if you're a woman and you go to a doctor and you're asked, when was the first day of your last menstrual period, you know how annoying it is to try and remember that. I can't even remember what I had for dinner last night, right? So it is a notoriously inaccurate measurement. Nonetheless, we use gestational age in most pregnancies to predict things like, when are you going to go into labor and when are you going to have your baby? And so that's why when we say baby comes early or baby's arriving late, it's probably not early or late at all. It's just a metric of the inherent variability and error in gestational age. So gestational age is what we mostly use clinically. And what we talk about, if someone says to you they're 13 weeks pregnant, they're likely talking about gestational age. When we talk about development to study it, we're talking about conceptional age. And because of the difference, this 2 weeks of ovulation time, conceptional age is 2 weeks shorter than gestational age. So the first period of prenatal development is called the germinal period. And that's fertilization to implantation in the uterine wall. Those are the two main events that bookend the germinal period. Here we have an ovary. The ovaries released an egg or an oocyte in ovulation. That egg is fertilized to become a zygote, and then the zygote travels proximally through the fallopian tube, bouncing and rolling along toward the uterus. That's where it's heading. Now, as it passes down the fallopian tube to the uterus, it undergoes cycles of cell division, and when it arrives in the uterus, somewhere around day 8 or 9 or day 10 or 11, it will implant in the uterine wall. Now, these are computer-generated graphics that give you a beautiful overview of the development of the human embryo. And just so you can see how small a zygote is, this is a 0.1 millimeter scale bar. So it gives you an idea of what a one-day pre-embryo or a zygote looks like. You can see 2 to 3 days. Now a cycle of cell division has happened, or 2, because I can see multiple nuclei in that pre-embryo. And finally here, somewhere between days 7 to 12, the embryo is implanted in the uterine wall. And so we've got fertilization, rapid cell division cycles, and ultimately implantation, all in the germinal period. I should say that these stages are named stages called Carnegie stages. That's not too important, but the days are important for you to know. Now, after the germinal period comes the embryonic period of development. And this is a truly remarkable period. It's a series of incredibly complex events and dramatic changes in a developing baby. So here's a 22-day-old embryo. That embryo is the dark peach colored part, does not look much like a recognizable child. Here's a 52-day-old embryo near the end of the embryonic period, and you can see now how much that has changed. The embryo has changed to look like a tiny human being. And so the changes in embryo and the embryonic period begin with cellular movements and differentiation, where cells acquire increasingly restricted fates. And it ends with these complex morphological changes, giving rise to recognizable arms and legs and face features, etc. So there is variability in growth in the embryonic period. So this baby is 53 to 54 days. It's about 15 to 17 millimeters from crown to rump. That's how they're measured. This baby's 30 millimeters crown to rump at 52 days. So there's some variability in growth. But what's remarkable is the amount of development that occurs in teeny tiny embryos. So that is the size, roughly, of a baby in your hand that's 54 days old. Now, we know from every process in our lives that anything that's complex is prone to errors. And the embryonic period is extremely error prone. When you look at everything that happens in the embryonic period, it is a miracle that any of us are here at all, that any of us made it through that period of development. And in fact, most fertilization events do not. So it's really important to appreciate that most conceptions don't result in a full-term pregnancy. Development stops prior to a live birth. And these data are hard to get, but most available estimates indicate that it's less than 30% or maybe about 30% of fertilization events that actually result in a full-term pregnancy. And that's true even for young fertile couples. So we break these percentages down. The schematic is called the pregnancy loss iceberg. And what it says is that most pregnancies begin and end before a woman is aware that she is pregnant. And so this would be early stages, certainly during the embryonic period, and often before a woman even misses a menstrual period. So here we've got 30% at the top of the pyramid of live births. And then we've got a line dividing clinical and preclinical pregnancy loss. So I'll explain what that means. With conception here at the bottom, about 60% of pregnancies end in the pre-implantation stage, so during the germinal period, or post-implantation, but very early on. And those are called preclinical pregnancy losses because mom is not even aware that the pregnancy loss occurred. So 60% of fertilization events end in a preclinical pregnancy loss. 30% end in a live birth, and about 10% of all fertilization events end in a clinical pregnancy loss or a miscarriage. And this is a pregnancy loss that mom is aware of. And these can be really emotionally difficult events for many women, and they're extremely common. So 10% of all fertilization events end in miscarriage. Chances are there's a woman you know who's had at least one miscarriage. We don't talk about this enough, but it's really common and can be very emotionally difficult and isolating for women. So many pregnancies end even before they begin or before we're aware that they began. Even in pregnancies that do proceed through and past the embryonic period, the complexity of the embryonic period is easily disrupted. And that renders the embryonic period exquisitely sensitive and vulnerable to changes in the prenatal environment. So let's look at this schematic. So this is the risk of birth defects being induced due to a change in prenatal environment. Increasing risk is on a sort of arbitrary scale on the y-axis. And on the x-axis, we have weeks gestation, so weeks in utero. So starting at 0 with fertilization, we've got the embryonic period, weeks 3 to 8, and then a very long fetal period ending in birth or parturition. Now, we can see that the risk of a birth defect being induced peaks in the embryonic period. And we can see exactly how problematic that is because 8 weeks is the average timing of the first prenatal visit. So babies are exquisitely sensitive and the process of development is vulnerable to disruption in a period where many women don't even know they're pregnant yet, and most women have not met with a physician to discuss prenatal health. And so this is a real problem, and this creates all kinds of risk to developing babies. Now, this schematic summarizes the critical sort of periods in human development. And early in the germinal period, if the prenatal environment changes, if there's damaging influences in the prenatal environment, it probably will just result in prenatal death. Probably the pre-embryo will simply be lost. If the prenatal environment is adversely affected in the embryonic period, there's likely to be major abnormalities. There's a real risk of what's called major morphologic abnormalities or a gross birth defect, something you can see when you look at a person. And that risk exists in the embryonic period. You can see the sort of dark blue bars indicate for each system a big risk of disruption. The lighter blue bars are a lower risk of disruption. And the dark blue bars are present for every system in the body in the embryonic period. In the fetal period, the risk is a little less. So it's relatively minor morphological abnormalities, and that's true across every system. You'll see that this slide indicates all action of teratogens. What is a teratogen? So teratogens are environmental agents with the potential to alter normal physical development or function if maternal exposure occurs within critical windows of development. So a long definition, but basically teratogens are any agent that has the potential to disrupt that prenatal environment and disrupt normal development. As we sit here, pre-embryonic stage, as we said on the previous slide, the pre-embryonic stage, probably death of the pre-embryo, should say, is possible. In the embryonic stage, the embryo is most susceptible to the influence of teratogens. And in the fetal period, the impact of teratogens is relatively minor. Now, I've underlined relatively. What's minor is the morphological abnormalities, so the things you can see with your eyes. Though impacts of teratogens in the fetal period are relatively minor compared to the embryonic period. You can still have severe functional deficits, and these include delays in cognitive development, social development, and motor development. So the fetal period is still a period of vulnerability. It's minor only relative to the embryonic period. Now, we typically classify teratogens into 4 categories. Physical agents like radiation and heat, maternal metabolic conditions, and that's not just pathological conditions, but general physiological conditions, maternal infections and diseases, drugs and chemicals, which we normally recognize as teratogenic agents. That's the first one everybody thinks of. And I'd like you to add a 5th here, which is psychological stress in mom, so maternal stress, now known also to be teratogenic. So let's start with physical teratogenic agents. So these include ionizing radiation and heat. And when I say heat, I don't mean sunny weather. I mean heat that has the potential to induce maternal hyperthermia. The evidence for the damaging effects of maternal radiation exposure come from multiple catastrophic natural experiments or horrific events, the atomic bombing of Hiroshima and Nagasaki, and the Chernobyl accident are the big ones. And children who were born after those events often, not always, but often had pronounced birth defects. So this is a Ukrainian child born with multiple gross birth defects. That means they're visible in gross anatomy. You can see them by looking at her. Photographed in a children's home in 1991. She was born soon after Chernobyl, which meant her mom was pregnant and exposed to radiation in the Chernobyl disaster. And you can see when you look at her, the first thing that's obvious is that her limb development is truncated. And she only has one sort of half-formed digit on her right arm. So those are gross birth defects. She may also have other defects that we can't see, errors in or delays in cognitive development or social development, for example. Now, the radiation that you would get clinically, like a clinical X-ray, is much less likely to impede growth and development compared to a catastrophic radiation exposure or bombing. However, it's still standard clinical practice to minimize in utero radiation exposure. And so women of reproductive age are asked whether it's possible they could be pregnant prior to radiation exposure, and if it's possible at all, precautions are taken. So that's radiation. Now, data demonstrating that maternal hyperthermia is a problem, that it's teratogenic, are less clear-cut. There's been large cohort studies, these data are on Danish women, that found no association at all between maternal fever in pregnancy and the risk of birth defects or congenital defects. Despite the lack of data, pregnant women are typically advised to avoid hyperthermia, including time in saunas and hot tubs, to avoid any theoretical risk. And the reason for these precautions is that animal studies of maternal hyperthermia have revealed teratogenic effects. So the data on humans are much less clear-cut for heat, but it's out of caution that pregnant women are advised that way. Now, the second potential teratogen has to do with the maternal metabolic environment, and that's governed in large part by maternal nutrition. So adequate prenatal nutrition, both in terms of caloric intake and vitamin and mineral supply, is absolutely vital for both embryonic and fetal development. Now, there's two terms, malnutrition and undernutrition, and they're subtly different. So malnutrition is an inclusive term for all types of imbalanced nutrition. That includes too few calories, too many calories, and an inappropriate selection of foods. So that's malnutrition. Mal from the French, negative, bad, so simply bad, poor nutrition. In contrast, undernutrition is a specific lack of something. And so it can be a lack of calories overall or a deficit in a specific vitamin or mineral. So undernutrition versus malnutrition. Now, the prenatal diet does need to increase in calories to cover the increased metabolic load, right? So baby grows fast, the placenta grows fast, and there is an increased metabolic load during pregnancy. However, sedentary women who are pregnant need to increase their caloric intake by about 300 calories a day. That is not a lot of calories. It is easy to overcorrect on that. Pregnancy can make you feel very hungry, can make you feel other things like emotional. And so 300 calories a day is actually the recommended amount to meet the metabolic demands in sedentary women. It would be increased, of course, depending on physical activity. And we'll get to that. Now, it's important not to overcorrect because gaining too much weight during pregnancy has negative health consequences, not just for mom, but also for baby. So there is a normal amount of weight women should gain or recommended to gain during pregnancy, but it's important not to way overshoot that or way undershoot that. And that amount depends on your BMI as a metric of where you are metabolically at the time of conception, when you get pregnant. So if you're underweight, you need to gain more weight to support a developing baby. And so you want to gain about a pound a week through your second trimester and even more in your third trimester. A total weight gain of 20 to 40 pounds. And if you're a healthy weight, when you start, you have a BMI between 18.5 and 25, then you want to gain 25 to 35 pounds in pregnancy. If you start overweight, a little bit less, so sort of a maximum of 25 pounds. And if you're obese, when you become pregnant, you really want to cap your pregnancy-induced weight gain at 20 pounds. And so these are the recommended ranges based on BMI. Now, we know BMI is not a perfect measurement. Women should always work in consultation with their physician, but these are the recommendations on average. In addition to sort of monitoring how much weight you gain, you need to alter your vitamin and nutrient intake in a few key ways. And you can see the percent changes here. So a big one is protein. So you need to increase your protein consumption level by over 40%. So that's really substantial. There's also a couple of vitamins and minerals and nutrients that you want to consider increasing. A big one is folic acid. So folic acid, prenatal vitamins contain folic acid to prevent neural tube defects like spina bifida, and so that's a big one. What's really critical though is you want to do this following recommended medical guidelines. So supplements and herbs and all kinds of things that are marketed ad nauseum to pregnant women are not necessarily beneficial. Worse, they're not necessarily innocuous. So they have the potential themselves to be teratogenic. So medical guidelines suggest key changes in protein and select vitamins. Going beyond that can pose a risk to developing babies. So why are maternal weight gain and caloric intake important? They're important because mom's metabolic state dictates in part baby's weight at birth. And baby's weight at birth is an important determinant of baby's health. So here's two babies. They're the same gestational age. You can see the difference in their size and their weight. Here's a baby on the left who's small for gestational age. And so being small for gestational age carries a set of risks. It's caused by some form of intrauterine impoverishment, or can be caused by that. And baby has lower body fat, baby achieves less growth prior to birth, and can confer some other risks. On the other end of the scale, we have large for gestational age, or babies larger than expected at the time of birth. And so that confers its own sets of risk. And some of these risks are lifelong. For example, a baby that's born large for gestational age may have an altered metabolism that's persistently altered. This isn't always the case, but it could affect their metabolism through childhood and even into adulthood in development. So really, you want to keep baby in this AGA range, an appropriate for gestational age range of weight. And that range is very large. There's a hugely normal range, but babies who are somewhere in this range have better, sort of easier time after birth, and birth itself is easier. So large for gestational age is a risk factor for birth-induced trauma. It's difficult to actually get an LGI baby through the birth canal. Now, one of the maternal metabolic conditions that has the potential to be teratogenic is gestational diabetes. So this is new onset diabetes during pregnancy. It's insulin insensitivity, and it typically resolves at the end of pregnancy, typically, not always, but it poses additional risks for baby if it's poorly controlled. So gestational diabetes can result in babies that are large for gestational age if mom's blood sugar is not controlled appropriately. It can also do other things to baby. So it can persistently alter lipid metabolism in the baby. It can disrupt things in the brain like synaptogenesis, the formation of neural connections in the brain, and even induce structural brain abnormalities. So again, this isn't every case of gestational diabetes. So personal note, I had gestational diabetes and my 17-year-old seems sort of okay. But if maternal hyperglycemia persists, that means mom doesn't control blood sugar, then you're at risk, putting baby at risk for a whole host of developmental problems, including motor deficits, higher risk of ADHD and autism, and cognitive impairments, including memory and decline. So the third category of teratogens that I want to talk about are maternal infections. Now, there's many maternal infections that can disrupt development, but we'll talk about three of the most common. So rubella and the associated congenital rubella syndrome, HIV and AIDS, and toxoplasmosis. So the first two, rubella and HIV, are viral infections. The third, toxoplasmosis, is a parasitic infection. So rubella, or German measles, is a highly contagious virus. In adults, it's often completely asymptomatic. In children who are non-vaccinated and infected, it produces a characteristic red rash that it's named for, and other symptoms. It's dangerous, particularly to pregnant women, because it's teratogenic prenatally. So if a woman who's, most people in the world are now vaccinated against rubella in early childhood. It's part of the MMR vaccine series, measles, mumps, rubella. If a woman is pregnant and unvaccinated and exposed to rubella in a critical period, her child can develop congenital rubella syndrome, or CRS. Now, it's most dangerous, the risk is highest to baby if a maternal infection occurs prior to 12 weeks of pregnancy, and there's no effect, or the baby is unaffected if exposure occurs beyond 20 weeks of pregnancy. So most dangerous in the first 12 weeks, still some risk within the first 20 weeks. And again, this is an unvaccinated pregnant mom who's exposed and infected with rubella. So the most common consequence, the most common manifestation of CRS is hearing impairment, and that's about 80% of children who are exposed in this early period of the pregnancy. There's additional effects, including cataracts, cardiac defects, low IQ or microcephaly, literally small head and small brain, and others, including an increased risk of autism. So, rubella and congenital rubella syndrome is an excellent argument for maintaining childhood vaccination throughout the population. It protects unborn children. Now, HIV, human immunodeficiency virus, which if untreated can progress to AIDS, acquired immunodeficiency syndrome, can be transmitted from mother to child. So it can be transmitted in breastfeeding, it can be transmitted in utero, and it can be transmitted in the vagina during birth and delivery. And this type of transmission is known as vertical transmission. Now, for this reason, pregnant women living with HIV are typically treated with zidovudine, which is a drug that blocks the action of the HIV enzyme reverse transcriptase and prevents HIV from multiplying. And so this drug reduces vertical transmission to low levels, maybe about 2%, provided mom has adequate prenatal care and access to the medication. Now, if that doesn't happen, early HIV infection in young children impairs cognitive and motor development. So common outcomes are low IQ, impairments in language development, as well as motor effects like hyporeflexia, low reflexes, and reduced fine motor skills. And these can persist beyond early childhood. So toxoplasmosis is infection with a parasite, Toxoplasma gondii, that's found in cat poop, as well as the poop of other animals. But cat poop is the common mode of transmission because many people have cats as pets. Now, in terms of teratogens, toxoplasmosis is often referred to as a silent infection. And that's because only a small percentage of children exhibit effects of toxoplasmosis infection at birth, but a whole host of other children have issues that are revealed later in childhood. And the effects of this parasitic infection in utero can include low IQ, impaired motor development, and impairments in hearing and vision. And so for this reason, pregnant women are advised to avoid contact with cat litter. There's a lot of downsides to pregnancy, but not having to scoop the cat litter is one small upside if you happen to have a cat. You can get somebody else in your family to deal with it. There's a whole host of drugs that affect prenatal development in multiple ways. And they can be divided in turn into three categories. Recreational drugs, which is what we tend to think of immediately, prescription drugs, and non-prescription drugs. And we'll start with recreational drugs, and you can guess from the image which drug we're going to start with. So recreational drugs are drugs that serve no medical purpose. And the most common recreational drugs are alcohol, tobacco, cocaine, and opiates. And all of these have pronounced consequences for prenatal development if used during pregnancy. So we'll talk about alcohol first. And the umbrella term is fetal alcohol spectrum disorders. So this includes all the range of possible effects of alcohol consumption in pregnancy. Fetal alcohol syndrome, under that umbrella, is the term most of us are familiar with. Alcohol-related neurodevelopmental disorders and alcohol-related birth defects are two other conditions that fall under the umbrella of FASD. And these two categories describe children who just exhibit some, but not all, of the clinical signs of fetal alcohol syndrome. So this table summarizes some of the effects of prenatal exposure to alcohol. And the short story is that prenatal exposure to alcohol can affect development of almost every organ system. So it affects growth. You have weight that's low for gestational age, which has other knock-on health effects. Microcephaly, which is literally small head or small brain. And then a whole host of CNS dysfunctions that are, of course, related to motor dysfunction. So 50% of infants with fetal alcohol spectrum disorders have poor motor coordination, they have a weak sucking reflex, they have low IQ, and so on. FASD, this is recent data, 4% of the Canadian population is impacted by FASD. 4%. So that's more children than those impacted by, and adults, because they live with it forever, than impacted by autism, cerebral palsy, and Down syndrome combined. So fetal alcohol syndrome in Canada and fetal alcohol spectrum disorders are a huge social problem. It's a lifelong disability and really important component of prenatal development. And I just want you to think back to that graph where the most vulnerable time for exposure is, and it's in 5, 6, 7 weeks of pregnancy before many women even know they're pregnant. Now, this paper talks about the interactions between psychological stress and maternal metabolic disorders and how those physiologically interact to create a fetal environment. And actually, it's a really interesting theory that these two teratogenic factors interact physiologically and together produce additive risk for mental health challenges after birth in childhood and in adulthood. So it's an interesting theory. What this diagram did for me, though, is make me think about the psychological stress in pregnancy that moms go through when they're worried about controlling their metabolic environment and every aspect of their developing baby. So, my personal experience of having gestational diabetes, I worried obsessively. Am I controlling my sugar enough? Am I doing a good enough job? I was super stressed. So then you get into, wow, what was the impact of that excessive psychological stress on the developing child? And so moms really need to be supported through pregnancy to minimize maternal stress. It has real ramifications for baby, and it's easy to get caught up in worrying so much about doing a good job and protecting your unborn child that your stress levels go up and actually could have a negative impact. So I just think that's a really interesting consideration and thing to think about in prenatal care and supporting pregnant women. Now, an additional component of the prenatal environment is maternal exercise, and maybe this is perhaps the easiest way to control maternal stress. So exercise in pregnancy is important to maintain health, physical and mental, but also to prevent pregnancy-related risks and complications. So some of these we've already talked about: excessive weight gain, for example, gestational diabetes. There's evidence that exercise prevents gestational diabetes. Not always. I tried, still got gestational diabetes. It also prevents a condition called preeclampsia, which is abnormal hypertension or high blood pressure that can put the pregnancy at risk. And so all of these are good reasons to exercise. But of course, it's good to exercise for physical and particularly mental health. And despite lots of myths, there's very little evidence to support risks to baby from exercise. So when you're pregnant, people tell you shouldn't do all kinds of things. Everybody from your mom to people you meet on the street have opinions about what you should and shouldn't do as a pregnant woman. So what do the recommendations say? Well, healthy women should get at least 150 minutes of moderate intensity aerobic activity per week, and that's true during pregnancy and in the postpartum period, so after delivery. And as always, you're limited by what your body can do. There's physiological changes. As baby gets very big, it pushes up on the diaphragm, reduces lung capacity, and it gets a little bit harder to do aerobic exercise. But your body kind of tells you what it's capable of. Now, there's some activities that probably you want to avoid during pregnancy. Contact sports is one in case of perhaps physical damage to baby. Skydiving is an interesting recommendation. And hot yoga or hot Pilates, things like that have the potential to induce hyperthermia and thus become teratogenic. But really, most things and many things you can do. If you're not a marathon runner when you become pregnant, perhaps pregnancy is not your moment to start training for a marathon. But in general, the benefits of exercise in pregnancy generally outweigh risks to baby. And a reminder that pregnant women compete at the highest levels of sport. So here's Egyptian fencer Nada Hafez competing 7 months pregnant while at the Paris Olympics in 2024. So generally, physical activity during pregnancy is a good thing and certainly achievable for most women.